This episode of Pupil Pod is sponsored by Tarsus. Tarsus Pharmaceuticals applies proven science and new technology to revolutionize treatment for patients, starting with eye care. Tarsus is advancing its pipeline to address several diseases with high unmet need across a range of therapeutic categories, including eye care, dermatology, and infectious disease prevention. Tarsus is proud to announce that Xdemvy Lotilaner Ophthalmic Solution 0.25% is now available to prescribe.
Welcome to the Pupil Pod, where we use clinical cases to guide discussions on board review topics. I'm your host, Sila Bal, and my guest today is someone that I personally really look up to in both ophthalmology, but also in life, Dr. Andrea Tooley. Dr. Tooley is an oculoplastic and orbital surgeon and the Assistant Residency Program Director of the Mayo Clinic. Dr. Tooley, thank you so much for joining me today.
Thank you, Sila. It's so great to be here. I should tell you that since July, I formally took over the program director at Mayo. So I'm PD. I'm just finishing my first year. It's so exciting, but I can't wait to talk to you all about orbit and oculoplastics. It's going to be great.
That's amazing. Congratulations. I did not know, but I'm so proud of you. And you are such an inspiration to look up to all the time. So good luck with your new role.
Thank you.
Yes, let's switch gears and talk orbit. So this is a case of a 33-year-old woman who presents with sudden onset periorbital pain and edema on the left side. On examination, vision is 20/20. There is no RAPD, and IOP is normal in both eyes. Right eye exam is otherwise normal. Her TEL shows measurements of 19 and 21. There is left-sided periorbital edema and chemosis. However, dilated examination is normal and extraocular movements are full. So, Dr. Tooley, first, could you walk us through the important orbital examination findings that we should evaluate in every patient that comes in with an orbital concern?
Sure. So even in your STEM here, you've given me a lot of great information. But when you're thinking about orbit or periorbital signs, symptoms, and things that can be affecting our patients in terms of pathophysiology, the orbital exam is critical. So just like every normal eye exam, we're going to start with things like vision, pupils, pressure. I'm always thinking in my head, is there an optic neuropathy? Because that for me is a real branch point when I'm thinking about orbital disease. And so something I tell my residents over and over is there an optic neuropathy? Yes or no? So that's one question that should always be in the back of your mind when you're thinking about an orbital process. So really paying attention to vision, it can be subtle. Looking at pupils also can be subtle if there's a small APD. I always do red DSAT or color if I'm really wanting a sensitive optic nerve exam. And then the next step after pressure, your dilated exam, everything is really looking at the extraocular muscles. That can point you to, is this more of an orbital congestive type process, or is there a cranial nerve palsy going on? Is there an orbital apex syndrome? It can really kind of point you to where you think the pathology is affecting the eye and what's going on. So the fact that this patient has no diplopia and her EOMs are full is very reassuring. And then I do kind of my external exam. Is there ptosis or is it just edema that's making the lid look low? Is there true proptosis? Do our Hertel measurements really show a difference in proptosis? Or is it just edema that's making it kind of relatively different? You can pay attention to things like chemosis, which might be present if there's orbital congestion. And so all of those things kind of put together can help you decide, am I really worried? Or do we think this is luckily mild? And usually with an orbital kind of issue, you have to get neuroimaging. And this is just the first step on a process, but we really need to see what's going on in the orbit. So all of these things are helping me put the picture together. And then my next step is usually neuroimaging.
It's so helpful. And I love that you immediately ask, is there optic neuropathy? Is there optic neuropathy? Because that is a critical piece of information that we need to elicit from the exam right away. So I'm going to backtrack here just a couple steps. And before we even get to the physical exam findings, what history questions would you want to know? Would you want to make sure you ask this patient anything that we hadn't mentioned when we presented the case that you really want to know about in these types of patients?
For this patient specifically, it's interesting that it's unilateral instead of a bilateral process. And so that can kind of change some of the questions that you might think about asking. So you want to ask about trauma. Did you fall and hit your face? Did somebody punch you? Is there something that, has elicited this periorbital edema? Um, and then the next thing that's kind of the most common things being common would be allergies, a history of allergic changes. Did you sleep on a new mattress? Did you get new detergent? Did you rub something in your eye? Do you have any exposure? Then you start asking the more systemic questions. Do you have any history of odd infections or odd travel or exposures to things that could be causing problems? Do you have a rheumatologic or autoimmune type history? Any inflammation type symptoms in your body? And then finally, any oncologic history, because we're always thinking about neoplastic symptoms. One thing that's really helped me with the orbital exam is the mnemonic vein. Have you ever used that mnemonic? It's such a good one for the orbit. So VEIN. And it basically encompasses anything that could be going on in the orbit, but it really helps you narrow and make sure you've asked the right questions and gotten the right test. So V could be vascular. So things like a varix or an AVM that is ruptured or a cavernous hemangioma that's causing proptosis. So any vascular thing. E is endocrine, which is usually going to be thyroid, but could be some other endocrinopathy. I is very broad spectrum, infectious or inflammatory. So any of your autoimmune type picture, any of your infectious type picture, even something like a conjunctivitis can really cause a robust orbital response sometimes. So that's in your I category, or I suppose idiopathic. And then N is neoplastic. So we unfortunately see metastatic lesions to the orbit. We see lymphoma affecting the orbit quite a bit, even in young patients. So N kind of encompasses that neoplastic. So if you think vein, you're going to pretty much get anything that could be on the differential for an orbital process.
I love that. I mean, that's definitely how I used to think through these things, but I never used vein as my mnemonic. And I love mnemonics, and our listeners should also love mnemonics because they really simplify your life, make sure you don't miss anything. So, vein, I'm going to remember that. Okay, so we did our vein, we have a differential, we went through our history, we have a thorough exam. I know you mentioned neuroimaging already. What are the additional tests that you want, and what neuroimaging do you like to start with, and how do you think about which type of imaging that you like to get for these patients?
Yeah, so in this patient who has a unilateral orbital process that seems relatively benign, no optic neuropathy, but there's something going on in her orbit and we don't have a good reason for it, I think you kind of get a broad spectrum inflammatory type workup. So we're going to get labs, basic inflammatory labs like ESR, CRP, you get your ANCAs. ANA and RF are controversial, but no one's going to really give you a hard time for getting some basic rheumatologic labs. Always get your thyroid function test because unilateral proptosis still the most common cause is thyroid eye disease. Even if it doesn't look like thyroid, it's a great masquerader. And then think of other great masqueraders like sarcoidosis and then infectious things like syphilis, TB. You always want to be kind of keeping those on your differential. So it wouldn't hurt to get kind of a broad spectrum workup. Something else that could guide you is whether or not the patient is having pain. Pain can be really important in an orbital workup if it's painless versus painful. And then in terms of neuroimaging, I usually start with a CT orbit with and without contrast. I think you can get almost everything from a CT. I usually only go to an MRI if the CT is very nonspecific or unrevealing. Then the next step is an MRI. It's much easier to get a CT, it's much less expensive. The radiation dose is still extremely low, it's safe for your patients. So I'd start with a CT orbit with and without contrast. The only time I skip contrast is in a fracture when you just care about the bones, then you can get without. But otherwise, I'd add contrast, get your basic inflammatory and infectious lab workup, and go from there.
All right, so let's say you sent the laboratory workup, all was normal, but the CT face shows a diffusely enlarged lacrimal gland with preservation of shape, enlargement of the medial rectus muscle with involvement of the tendon, and enhancement of orbital fat. The sinuses were not involved. Could you tell us a little bit about what's on your differential at this point now that you have the imaging, and what your differential is kind of for orbital inflammation in general?
Yeah, this is a great scan result that could encompass like many differentials. So this is a nice scan to think through because one, you've got lacrimal gland enlargement, which is going to be really common. Our lacrimal gland is a glandular structure. It really responds to inflammation and anything that's going on in the orbit. So even with thyroid eye disease, you can have lacrimal gland enlargement. So just because you have lacrimal gland enlargement doesn't mean that it's definitely dacryocystitis or dacryoadenitis. It doesn't mean that it's anything slam dunk. It just means that there's some inflammatory process going on. But it's great that you have that, and then you have this one muscle enlargement, just a single medial rectus. Also, kind of a common muscle with thyroid eye disease, but here we see involvement of the muscle tendon that points us a little bit further away from thyroid. So most likely less likely thyroid. We hear all the time about IgG4 related ophthalmic disease or related orbital disease. IgG4 really kind of came on the scene in the early 2000s as a new entity to describe this subset of previously IOI, idiopathic orbital inflammation. IgG4 can really look like anything. And so you could always get a serum IgG4, but it's mainly a histologic diagnosis. You have to get a biopsy. So you could add on a serum IgG4. This scan doesn't look classic for IgG4, although it can really do anything. One very common thing that could be board's kind of buzzword noteworthy is enlargement of the infraorbital nerves. I don't know if you've heard that, but if you see infraorbital nerve enlargement, that's often IgG4 until proven otherwise. So at this point, we're thinking probably in the IOI or idiopathic orbital inflammation kind of genre. Could still be like a dacryoadenitis or orbital inflammation related to a viral infection, less likely with a medial rectus enlargement. Still could be neoplastic, like a lymphoproliferative lesion. It could still be a lymphoma or a low grade kind of MALT situation that's affecting lacrimal gland and medial rectus. Slightly less likely. My guess, especially in this younger patient, a 33-year-old, would be an episode of IOI. So that would be kind of my leading differential at this point. And going into that, you want to make sure you're not missing any infectious disease. The scan will help you with that too. Something like an orbital cellulitis seems pretty unlikely in this case, but you want to make sure there's no sinus involvement. And if we think the sinuses are clear, then I think we've got the go ahead to assume this is non-specific idiopathic orbital inflammation.
So, given that IOI is your leading differential right now, when or if when do you ever biopsy these patients? So, do you treat them? Do you biopsy? What kind of leads you in one direction or the other?
It's a great question to ask, when do you biopsy or not? And I think at the end of the day, no one will ever fault you for getting a biopsy, and it's never a bad decision to get a biopsy. And I tend to be on the biopsy camp when I see these patients. You can have a frank discussion with the patients about risks and benefits of biopsy. Let's say they just had one muscle enlarged, like let's say it was just superior rectus and no lacrimal gland enlargement and nothing else. That's not a really friendly muscle to biopsy. Having a vertical phoria or tropia is really hard for your brain to deal with, and small amounts of injury to the superior rectus could give you double vision. Versus like lateral rectus, you could probably take a big chunk of it and they wouldn't get double vision. If they have lacrimal gland involvement, that's great because it's a really easy target for a biopsy. It's anterior, it's not hard to access, it's right there. Let's just biopsy it and see what it is. So I think you have to decide the risks and benefits of biopsy and really have a frank discussion with the patient. What's the risk of double vision? What's the risk of vision loss or dry eye or something, a sequelae if we do decide to do a biopsy? Versus, should we just treat you with steroids, see what happens, and go from there? The option in idiopathic orbital inflammation is always to just treat with steroids. You can do 1 mg per kg of oral prednisone, taper them down slowly, and if they get better, I tell my patients this is an autoimmune disease that affects your eye socket and usually nothing else. And sometimes you might have one flare and then that's it, never again in your life. Or maybe it'll come back in 5 years. And so, in those patients, if they respond beautifully to steroids, I don't think it's unreasonable to forego the biopsy in that instance. In this patient with a very large lacrimal gland, I might talk to them about it, especially if there's any other labs that are concerning, like say their ACE was elevated or their chest x-ray was a little bit strange or their ANCA was elevated. It's like, well, maybe it would be helpful to know. But let's say her labs were stone cold normal, We start her on prednisone. She responds beautifully. Symptoms are totally gone. I tell my patients, I'll give you one chance. And then if you flare again, then you bought yourself a biopsy. So you have that discussion and you decide if there's multiple flares, then you definitely biopsy.
I really love that. And it is just so important to talk to our patients and let them kind of be the driver for their care, to give them our professional opinion, kind of discuss the options with them, and then allow them to at least feel as though they're part of the decision making process, which I think is something that's changed in the last 20 years in medicine. We've shifted away from that paternalistic view. So let's say you decided to do a biopsy on this patient for whatever reason. They had some abnormal labs, or they decided that they were really anxious and they wanted the biopsy. What would you expect to see for an IOI patient on biopsy?
So IOI is going to be that non-specific inflammatory picture where you don't have clonal populations of cells that are proliferating. You don't have a higher degree of plasma cells or monocytes. You see kind of that pleomorphic cellular infiltrate. So that's kind of the buzzword that you'll hear for that. But you'll see lymphocytes, plasma cells, sometimes eosinophils, depending on what the underlying situation is, and then some kind of underlying fibrosis is most common. You shouldn't see a vasculitis type picture. You shouldn't see granulomatous inflammation. It should just be kind of that more benign, broad inflammatory picture that's a little bit more mundane with that reactive fibrosis. So that all really reassures you that there's not a lymphoproliferative process. Or if you see something like granulomas or vasculitis, then you really have to start thinking there's something else going on here. But if you see just the regular cellular infiltrate with a variety of cells on biopsy, you're good to go.
So we've mentioned vasculitis a couple times now. Let's just pretend that this patient came in with bilateral simultaneous orbital inflammation. What is something like vasculitis that you would think of, and how would you kind of work through that process if instead of IOI you were concerned about something like that?
When I'm thinking that there's more of a systemic picture going on, that there's a systemic autoimmune disease, something like granulomatosis with polyangiitis, GPA, or something like sarcoid that's driving this picture, I work really closely with rheumatology. And what I found is that they always want histology. So that's where the biopsy is critical. And the biopsy will then point you to, is this GPA? Is this something like sarcoidosis? We just had a patient the other day with horrendous GPA who was unable to get care for quite some time, came in, count fingers in one eye, 2100 in the other, with bilateral orbital dense infiltrates and basically an orbital apex type syndrome where the eyes weren't moving at all. Did a biopsy, granulomatous inflammation with high levels of vasculitis. And so immediately that patient can be started on rituximab. They can get the treatment that they need because steroids just aren't going to cut it. But in those situations where you think there's a systemic process and you're really worried about the eyes, let's say there is an optic neuropathy or there are really dense orbital infiltrates, in that case, I treat the patients with my kind of optic neuropathy dose of prednisone instead of just an orbital inflammation prednisone. So the optic neuropathy dose is you admit the patient for 3 days and it's 1 gram of solumedrol a day for 3 days. So IV methylprednisolone for 3 days, a gram. Otherwise, if you're doing outpatient, then it's just 1 mg per kg PO, but that's not in optic neuropathy. So if there's an optic neuropathy, you admit them, you really give them the high dose IV steroids, and then you go from there. And you hope to get them on a steroid sparing agent to address the regular immunologic condition that they have going on.
So, in the realm of systemic manifestations of orbital inflammatory disease, so we talked a little bit about GPA, we talked about the vasculitides within that realm. What about sarcoidosis? What about orbital sarcoidosis? What would you expect to see? How do you manage those patients?
Yeah, orbital sarcoidosis is interesting because there's a subset of patients where it's really just pretty much affecting the orbit versus your patients who have systemic disease. And it's so important for us to make sure that our patients are getting the help that they need if they have systemic disease. Their pulmonary involvement, their cardiac involvement. Cardiac sarcoid is really scary. And so it's our job. We can be one of the first to make the diagnosis for these patients, and we need to get them going on what they need. So for sarcoid, all the buzzwords and the things you need to know is that on biopsy, you see those classic non-caseating granulomas. They can be involving any organ, but that's what you're looking for on pathology. Usually we're seeing it in the lacrimal gland, but you're also looking for that bilateral hilar lymphadenopathy. That's why we always get chest imaging for these patients. That's more sensitive, more specific than getting an ACE, which can be misleading. So you can't just rely on the ACE. You have to get chest imaging for these patients. The thing to know about ACE2, it's produced by the epithelioid cells and the macrophages found in the granulomas. And so it can reflect how many kind of the massive granulomas that you have and the severity of sarcoid, which also isn't why you can just hang your hat on ACE. You have to get the systemic imaging. So that's sarcoid. I've had a few patients who've come back with or have presented to me with just orbital involvement, and then on their diagnosis have ended up having bad sarcoid affecting their cardiac function, pulmonary function, and need to be started on methotrexate right away. So this is an instance where we're not just eye doctors, we're medical doctors. And so we really get to use all that background knowledge to make sure the patients get the full body treatment that they need. So that's in sarcoid. And then the same thing with GPA, with granulomatosis with polyangiitis. So GPA is a very scary disease. It has a mortality extremely high, like close to 50% if left untreated. So imperative to make sure that your patients are treated. And the key to that is that it's a small to medium vessel vasculitis. So that's what you see on path. You see the vasculitis, you see granulomatous inflammation, and necrosis. Those are the three things, the three buzzwords that you have to have. C-ANCA is the most specific lab test for it, but you can have ANCA negative. You can have seronegative GPA. And so again, you can't rely on our serologic testing in either of these. And then these patients usually have bad sinus disease. They'll have bad sinus disease, but they can also have pulmonary involvement and renal involvement. Those are all the key things to know about GPA. So bad actors, bad systemic things, and we can really catch them and help shepherd the patients to where they need to be to get the systemic treatment they need.
It's one of those things that as ophthalmologists, we always take such pride in. Like, we can diagnose most things by just looking at your eyes, but it's really so beautiful that we can do that and that we can provide that level of care to our patients. And potentially, I mean, like your patient, save their life just through them seeing you first. Can you just final question related to IOI and orbital inflammatory disease, tell us a little bit about how these things might affect children and how pediatric patients present a little bit differently than adult patients always, but specifically in this realm?
Yes, pediatric patients are different. They're completely different. I've found that their orbital inflammation can be quite severe, actually, and it's often in conjunction with other systemic um, immunologic issues like rheumatoid arthritis or some kind of histologic abnormality of plasma cell dyscrasia or something like that that I've seen in kids. You have to be really careful with kids because they can get bad bilateral orbital involvement quickly. And we worry so much about diplopia that's not resolving in kids, causing amblyopia, or even just the psychosocial impact of having orbital inflammation not looking normal. I see this the same in thyroid kids. It really affects their life. And so I think the most important thing for kids is working really closely with rheumatology as much as you can, because you have to get them systemically optimized. You can't just treat kids with high dose steroids like you would an adult. And so you have to get their whole body optimized, and steroid sparing therapy, even if it sounds like really heavy hitting, hardcore immunosuppressives that you might not want to give to a kid, that might be the best option for them so that they can live the most normal life and prevent progression. So I've seen some bad like histiocytic disorders in kids that cause really, really tricky orbital inflammation to treat. And I rely on their systemic therapies to help keep it at bay.
Yeah, it's so important to remember that even if we are reluctant to sometimes treat these patients with the heavy hitters, like you mentioned, they do give them the best potential for quality of life. So I think that that point is just so important to remember, because you cringe a little bit thinking like, oh, am I going to give this 10-year-old this monoclonal antibody that can be really chaotic for them? But it's just something that will actually improve their quality of life. Okay, so circling back to our case, so this patient likely had nonspecific orbital inflammation. You kind of alluded to this already when you were talking about having those conversations with our patient to guide biopsy versus not and treatment versus not. But can you just round the case off for us? Tell us how you would counsel this patient about her prognosis and kind of what you would do moving forward for someone like her.
So I found that that nonspecific orbital inflammation can be not a terrible diagnosis for people if it's not IgG4, if we haven't found anything else except just kind of benign inflammation on the biopsy. Either they respond once to prednisone, maybe they flare again, and we get them into rheumatology. I found that these patients often, it's not a life sentence of immunosuppression. Sometimes they'll do rituximab or methotrexate for a year or two and then be able to be taken off of it, and they stay quiet for a long time. And so I try to always give my patients a little hope. This isn't a life sentence, but it is an autoimmune disease in your body that's affecting your eyes, because they always it's not satisfying for patients when we say, oh, it's called idiopathic orbital inflammation. That means we don't know what's causing it. I think patients really crave a diagnosis. They want to know what it is. And even if I explain, like, well, we know what it is, it's IOI, they still say, oh, they didn't know what it was. And so being able to tell my patients, you have an autoimmune disease, it only affects your eye, it's not going to affect anything else in your body, but it does predispose them for other autoimmune issues in the future. So I just say you need to keep an eye on your health, pay attention to how your body is doing, take good care of yourself. And then hopefully it's not a life sentence of immunosuppression. They'll usually do really well. The patients who are relapsing and remitting and who have really difficult, like you hear about that sclerosing orbital inflammation where the eyes just get sucked in and the orbits are so inflamed and there's just nothing we can do. Luckily, I think those are few and far between these days. We have really great systemic therapies and really great rheumatologists, and you just don't hear about those as much. Complicated pathophysiology like Erdheim-Chester and all of these really bad orbital inflammations. They're few and far between. So in terms of IOI, I'd say fairly good prognosis. I see these patients about every 6 months as long as they're doing fine. And I tell them, especially if they haven't had a biopsy, I tell them the second you flare, you call me immediately and we do a scan and then a biopsy the next day if they haven't been biopsied. If we're say, we'll just treat you with prednisone, you're going to get better. And then I say the day you flare, you call me, we'll do a scan, see what's a target for biopsy, and then we'll biopsy you the very next day. So you have a lifelong relationship with these patients. They know their disease. They know when they're going to flare, and they can call me and say, hey, I'm having a flare. I've had a couple patients with Crohn's or ulcerative colitis who are prone to orbital inflammation. And it's probably related to their Crohn's or related to their UC. So it's not technically IOI. It's all part of the same clinical picture, but they know immediately when they're going to flare. And these patients, you have a lifelong relationship with them, kind of dealing with their eyes. But for the most part, I think they do well. You can manage this, and they'll be okay. So giving those patients some hope is really important.
I love that. I feel like I've said that 10 times this episode, but I love you and I love the way that you think about your patients and I love the way that you talk to your patients, but giving them that hope and not saying non-specific orbital inflammation, but really making it something tangible for them to sink their teeth into and feel like, okay, I know what this is. I know how to deal with this. I have a team working with me together to address this issue is just so unbelievably important for overall patient care and wellness and well-being. So I really love the way that you discuss these things with your patients. Dr. Tooley, before we end the episode, I ask all of my guests, if you could have dinner with one person from any time or place in the history of humanity, who would it be?
Okay, I have been thinking about this question for multiple days now. Like who? So there's so many people, but I don't want to be boring. The natural thing is to say I would love to see my grandmother who passed when I was young, just to talk with her about her life. I wish I'd had a better relationship with her. So of course my grandmother. I think someone alive that I'd love to sit down with is Barbara Kingsolver, who's an author. Have you read any of her stuff? She's so great. I'm borderline obsessed with her. She's written a few beautiful books, but she lives on a farm, just like similar to my lifestyle, completely grows all her own food, does all her canning, and she wrote a beautiful book about her experience living with her two daughters only on things that they either grew, meat that they raised, or something they could get from a neighbor. Like they didn't buy anything from the store, like no bananas, no coffee, nothing like that, unless they could grow it. They're in Virginia. It's called Animal Vegetable Miracle. She also just wrote Demon Copperhead, which is a modern day adaptation of David Copperfield, which was beautiful. She wrote the Poisonwood Bible. Anyways, she's like my author girl crush. So I'd love to have lunch with Barbara. If you're listening, Barbara, let's have lunch.
I'm not sure that she's our target audience, but I will definitely link her to this and tag her in
Yes,
it and just
please
let
do.
her know that she needs to have dinner or lunch with you. That sounds
Yes, I'm
amazing.
obsessed.
I'm going to add it to my Goodreads. I feel like I always get really good book recs from you. So I'm definitely
Oh,
adding
yeah.
that and we'll let you know how it goes. But Dr. Tooley, thank you so much for joining us today. This was an incredible episode. It's always so great to talk to you.
Thank you, Sila. It was wonderful to be here. I really appreciate you. Thanks so much.
And thank you to those tuning in. See you next time on the Pupil Pod.